Treatment. Prophylactic treatment. See page 379. Palliative and symptomatic treatment. The patient suffering from renal calculus may require palliative treatment under the following conditions. 1. During an attack of renal colic. 2. During a period of quiescence. Treatment of renal colic. Renal colic calls for the relief of pain, not only as a means of alleviating suffering, but also for the purpose of relaxing the ureteral spasm about the stone and expediting its passage into the bladder. Morphine should be given subcutaneously with a generous hand, and the patient put to bed and swathed in hot blankets if the attack is severe. Sometimes a colon irrigation seems to help to dislodge the stone. If the attack continues, the ureter should be catheterized and glycerin injected in the hope of relaxing the ureteral spasm. Severe pain may require general anesthesia for its relief. At the earliest possible opportunity, an X-ray should be obtained, since the need of operation may suddenly arise. The persistence of a swollen and tender kidney after the colic has ceased is suggestive evidence of the fact that the ureter remains occluded. Therefore, if the kidney remains tender, the ureter should be catheterized to determine whether the ureter is occluded. If so, the case should be treated as one of anuria and instant operation urged. But if the colic passes without leaving any tenderness or swelling in the kidney or any evidence of acute renal infection, the patient should nevertheless submit to thorough X-ray examination and cystoscopy with the use of the wax-tipped catheter and of injection for the purpose of diagnosing the situation of the stone and hastening its passage into the bladder. Treatment of calculus anuria. As soon as calculus anuria is diagnosed, i.e., as soon as it is known that there is anuria and that the anuria is due to calculus, operation should be performed. Delay is inexcusable except for the purpose of making the diagnosis more accurate. If the patient is seen in the first day or two of the anuria, he should be x-rayed for the purpose of locating the stone, and an attempt should be made by the passage of ureter catheters and the injection of glycerin to relieve the anuria. No more than 24 hours should be spent in this effort, and if the anuria has lasted for more than 3 days, not even this waste of time is permissible. Operation must be performed at once. Watson and Cunningham collected 205 cases of calculus anuria, of which 95 were operated upon with 46% mortality. 110 were not operated upon with 72% mortality. Huck states that operation before the 4th day gives a mortality of 25%, before the 5th day, 30%, before the 6th day, 42%. No matter how perfect the X-ray picture, there must always remain some doubt as to the condition of the kidneys or the existence of secondary kinks above a stone low down in the ureter. Therefore, it is almost a universal rule that the X-ray findings should be neglected, and pyelotomy performed solely for the purpose of saving the patient's life and removing any stones that may be found in the pelvis of the kidney. Watson has suggested that the pyelotomy should always be bilateral. I have acted upon this suggestion 2 or 3 times and have never had cause to regret it. There is certainly a lesion in both kidneys. The patient's life is seriously endangered through their lack of function. They had both better be drained. No immediate attention need be paid to a stone low down in the ureter. With relief of pressure by drainage of the kidney pelvis, this stone may pass spontaneously and with scarcely any pain. I have twice known this to happen after operation for calculus anuria. Treatment during a period of quiescence. Patients known to possess renal calculi, which are not causing symptoms, fall into 2 classes. 1. Patients who have not passed the ureteral calculus that has caused a colic. 2. Patients whose renal calculi have remained silent in the pelvis until they have attained a great size and have caused grave pyelonephritis or pyonephrosis. If a ureteral calculus having caused a renal colic remains in the ureter, and radiography shows that its transverse diameter does not exceed 1 centimeter, every effort should be made to encourage its passage. The patient should drink as much water as possible, and attempts may be made at oil injections through the ureter catheter, though these usually fail. Fully 1/2 of such calculi pass spontaneously, however, and one may properly await their discharge for fully 6 months. If a radiograph is taken from time to time and shows that the stone is moving downward toward the bladder, this is an encouraging symptom, while the recurrence of colics and immobility of the stone discourage delay. Precisely how long one should wait in any given case must be decided empirically. I once encouraged a patient to await the passage of his stone, this being halfway down his ureter and causing him little impairment of the renal function. Yet his next colic was followed by rupture of the ureter. I performed an emergency operation, and he recovered after a stormy and prolonged convalescence. If the stone is 2 centimeters or more in width, it will probably not pass, and dangerous complications may be prevented by early operation.